So our project is on capnography and cardiac output. It's by Cayla, Vanotti, and Larry Borja. First of all, what is cardiac output? Cardiac output is the total amount of blood the heart can pump per minute. It is abbreviated as CO. Some of the terms that you should know before we get into it is systole, which is the time period when the heart is contracting, specifically the ventricles. And that's related to what we call the end systolic volume, or the amount of blood remaining in the ventricles after a contraction. Diastole is the time period when the ventricles fills with blood, and that's related to what we call the end diastolic volume, or the amount that fills the ventricles prior to a contraction. Cardiac output can be determined by the formula of heart rate times stroke volume. And the stroke volume can be thought of as the volume of blood ejected by the left ventricle on each contraction. And the stroke volume is influenced by a few things. First of all, preload, afterload, and contractility. A normal cardiac output is about 5 liters a minute, but the range is 4 to 8 liters per minute. And on average, the stroke volume is 70 mLs per beat. So average end diastolic volume is 120 to 140 milliliters, and the average end systolic volume is about 50 to 70. So an example would be at end diastolic volume of 120 minus the end systolic volume of about 50 equals about 70 milliliters a beat. And what's also related to this is what we call the ejection fraction. It could be viewed as the percentage of blood that's actually being ejected from the left ventricle that works its way systemically throughout the body. And that formula is stroke volume divided by the end diastolic volume. The average is between 50 to 70%. So an example would be if we had the stroke volume of 70 milliliters divided by 120, which would be the end diastolic volume, times 100 to give you the percent, it would be about 58%, which is within that average range. So like I said before, the cardiac output is the heart rate times the stroke volume. And the average heart rate is about 70 beats per minute. The heart rate is influenced by many factors, some including the sympathetic nervous system and the parasympathetic nervous system. There are some drugs that can affect the heart rate, and we call those chronotropic agents, and those are medications that change the rate. If we want to speed up the rate, those medications are called positive chronotropic agents, and if we want to slow down the heart rate, those are called negative chronotropic agents. So like I said before, the stroke volume equals the end diastolic volume minus the end systolic volume. And preload is the combined forces that contribute to the stretch of the ventricle walls. Sometimes it is thought of as the force that stretches the resting cardiac muscle to a certain length just before the contraction. So like I said before, the preload is related to the end diastolic volume, or what they abbreviate as EDV. Afterload is the combined forces, or resistance, the ventricles must overcome when stimulated to contract and achieve end of systole. The amount of blood remaining is the end systolic volume. And contractility is the third part of what influences stroke volume. And contractility is a force of contraction of the heart muscle. So the more forceful the contraction is, then the more blood it ejects. And those can be controlled or influenced by medications as well, which we would call inotropic agents, and they change the force of the contraction. So if we want to increase the force of the contraction, we would call those positive inotropic agents. And if we want to decrease the force of the contraction, we would call those negative inotropic agents. So there's relationships that we have with these factors. So if contractility is increased, then the stroke volume is increased. For preload, if preload is increased, then the stroke volume is increased. And afterload, if afterload is increased, then stroke volume is decreased. So afterload has an inverse relationship and the others do not. So some things that can affect the afterload are hypertension, or an increase in the systemic vascular resistance will increase the afterload. Plaque or an occlusion can also increase the afterload. And when that happens within our blood system, the afterload has to produce much more force to get that blood out systemically to our body.
What is capnography? So capnography is a non-invasive technique that we use to measure the partial pressure or maximal concentration of carbon dioxide at the end of an exhaled breath. There are a couple different phases to capnography. There is phase 1, phase 2, phase 3, and phase 4. And when we're measuring capnography, we need to know what the normal values are for it. And so the normal end-tidal carbon dioxide values are 35 to 45 millimeters of mercury. And that's important because based on those values, we can know whether the patient is ventilating properly or not ventilating properly. So just a little quick example of ways that capnography is measured. There's two different kinds of ways. There is a side stream device and a mainstream device. The differences in these devices are that the side stream monitoring is used for patients who are not intubated. So, for instance, if somebody is going to have a procedural sedation, that would be done with a side stream device. The mainstream way we measure is done for patients who are intubated. So instead of the measuring coming from the nares, which is what we use for the side stream, it just looks like a nasal cannula. With the mainstream, it's actually attached to the endotracheal tube, and that is how we measure carbon dioxide on intubated patients. So there's a sensor that is located in the main unit, and CO2 is aspirated via a sampling tube. So that's just a little example of the different ways that we measure carbon dioxide, sorry. And then for capnography, there is different waveforms that we look at when we are looking at capnography. So it's kind of the same as looking at waveforms on a ventilator for your flow, for your volume, for your pressures, except this is what we look at to determine what is going on with the patient. So capnography waveforms can be used to determine information about both circulation and ventilation before, during, and after cardiac arrest. Each ventilation will produce a waveform, and the respiratory rate will be displayed with the end-tidal CO2 reading. So the different phases, I'm going to break them down and what each one measures. So phase 1 is the beginning of exhalation or baseline, and there is no carbon dioxide present. In this phase, no gas exchange occurs, hence is why it's called dead space. In phase 2, this phase, carbon dioxide from the lungs reaches the upper airway and mixes with dead space air, which causes a rapid increase in CO2. Carbon is detected using capnogram in exhaled air. It is also called an ascending phase or early exhalation. In phase 3, there is CO2 recorded uniformly in the nose, mouth, and lungs. And lastly, in phase 4, it is called an end-tidal phase. It shows the start of inspiration. This phase is also called the descending phase because oxygen fills when inhalation begins and CO2 concentration decreases. There's 5 different characteristics to a CO2 waveform. There is the height, the frequency, the rhythm, the baseline, and the shape. The most reliable method to confirm placement and documented proof that the airway remained in place throughout the course of care. So we use the waveforms for documented proof of that. So here's just a picture of the different types of waveforms that you might see for end-tidal CO2. So you have the normal, which is what you would want to see, indicating that your values are in range, so they are 35 to 45. You have bronchospasm, which is this one right here. So if a patient is having bronchospasm or a patient has asthma, this is the type of waveform that you might see, and this would be indicative of an end-tidal greater than 45. On this one right here, you have an increase in CO2, so the patient would be hypoventilating. Once again, the end-tidal would be greater than 45. In this one right here, you have decreasing end-tidal, so that would be hyperventilation, and that would be when your end-tidal is less than 35 millimeters of mercury. In this one right here, this is showing rebreathing of CO2, so that can be very dangerous, rebreathing your end-tidal, because that would mean that your end-tidal was greater than 45. This one right here is called Curar cleft, and your end-tidal is within normal range. However, there is this little divot right here. Typically, this happens when the patient is on a ventilator, and the depth of the cleft, which is this right here, is proportionate to the degree of muscle relaxants. In this one right here, this is what you would see during cardiac arrest. So this would be an indication of decreased cardiac output or decreased pulmonary blood flow. So this is what you would see in a sudden decrease in carbon dioxide. And then this right here is what we call ROSC, so it's return of spontaneous circulation. So that happens when CPR is being administered to a patient. So this shows CPR is being done, and then this right here shows successful defibrillation, and then this is the return of spontaneous circulation. This picture, I just wanted to include it because it shows the different phases of end-tidal monitoring. So you see phase 1 right here, phase 2 right here, phase 3, and then this is technically phase 4. So I just wanted to give like a visual representation of the different phases. And this would be when you were looking at a waveform. So there's a couple different things that we use capnography for. So capnography can be used for multiple purposes: general anesthesia administration, procedural sedation, analysis of ventilation, monitoring patients with cardiac and breathing diseases. It can be used in sleep studies and monitoring the position of an endotracheal tube. So capnography is really important during a code when somebody is in cardiac arrest, because it can give us feedback on the quality of the compressions that are being performed. So for example, an end-tidal reading above 15 millimeters of mercury would indicate that compressions are generating perfusion. It's important to know what an end-tidal below 10 means, because it can mean that the compressions are not being compressed how they should be, and it can mean that there's low perfusion and metabolism after a long downtime of shock despite good compressions. So it's important to know your values and what they mean, because that's what makes capnography so effective, is knowing what is going on in the body based on end-tidal readings. So like I showed you on the waveforms, the return of spontaneous circulation, which is what we call ROSC. So when you see a sudden increase in end-tidal, that's often our first sign that the patient has developed ROSC. So just to kind of recap, consistent high-quality compressions are essential for cardiac arrest resuscitation. A higher end-tidal CO2 during resuscitation correlates with improved cardiac output and the patient's outcomes. When ROSC is suspected in a patient, compressions need to be stopped and pulses need to be reevaluated. It's important to remember when, during a code, when you're delivering compressions, that if you suspect ROSC and you see if you have them on some type of capnography, you need to be aware, because if circulation is returned, you need to stop the compressions to be able to check the patient's pulses. So why is capnography important? Well, it's important for a lot of reasons, but the number one reason that capnography is so important is because it allows a provider to differentiate between sick versus not sick. So it can determine whether there's adequate ventilation and circulation, and it's a non-invasive way that we can determine this. We don't need any kind of invasive equipment to determine whether a patient is adequately ventilating and circulating oxygen throughout their body. And it also will help us determine if a patient is metabolically stable. So if there's irregular amounts of carbon dioxide in the patient's breath, it can tell the healthcare provider a great deal about the patient's condition. So for example, whether their CO2 levels are too high or too low. Patients who have seizures are often confound. Capnography can readily determine if a seizing patient is apneic or breathing during their seizing. While they are seizing, they can determine that. And also would obviously determine whether their breathing was effective or ineffective, hence whether they are apneic or not. So it's a very important tool to use, and there's no reason we shouldn't use it, because once again, it is non-invasive, and it seems like a little thing, but it can determine a lot. So something that I also wanted to talk about was how capnography and cardiac output correlate with one another. So it's very important how these two correlate. That's why capnography is so important during codes. So capnography has a ventilatory and circulatory component. The exhaled CO2 depends on the adequacy of circulation to the lungs, which provides clues about circulation from the rest of the body. So low end-tidal can indicate shock, poor systemic perfusion. Cardiac arrest is the ultimate shock state, meaning that there is no circulation or metabolism and no CO2 production unless effective chest compressions are performed. An end-tidal greater than 30 is associated with the cardiac output more than 4 liters per minute. So basically, as the cardiac output increases during resuscitation from shock or cardiac arrest, respirations become the rate-limiting controller of the end-tidal CO2. So increases in cardiac output and pulmonary blood flow result in better perfusion of the alveoli, and that is what helps rise end-tidal and CO2. Decreased presentation of CO2 to the lungs is the major rate-limiting determinant of the end-tidal CO2 during low flow. So it's just very important to understand how these two correlate with one another. So if your cardiac output is increasing, then you know that compressions are effective, and you can also determine that by looking at your capnography waveforms. I think that this is super important also because it can kind of guide us on the state of the patient. So yeah, that was our presentation on capnography and cardiac output. these are the sources that we use to gather our information.